As a clergyman, I've been working with people in the field of health for some 40 years now. And I've been working in teaching and research hospitals and in small clinics, particularly in churches where we have been developing a pattern of taking care of people by trying to approach them with a holistic approach. In these clinics we have a physician who has concern for the spiritual dimension of life. We have a nurse with similar concerns and a pastoral counselor who has specialized training in clinical psychology and clinical theology. So we've been trying to figure out, what does American medicine look like and what can we do about it? My particular field of interest has been in the area of prevention, preventive medicine. And so I found myself moving out from the medical school out into communities where I could test out the idea of how do you deal with people in the early stages of illness. Only recently, a famous medical clinic in America determined that 50% of the patients they see have illnesses that could have been prevented. So I'd like today to talk about the idea of how does illness begin? Usually it begins slowly, it takes time, and in a way, it's the body trying to tell us something about ourselves. In fact, it's almost like a play or like a drama in 3 acts. And so let me describe that with a wedge first, and then I'll divide that into the 3 acts of illness, and that's the title of what I'm going to talk about, the 3 acts of illness. So we'll take the wedge. And we'll say that over here are people who are well. And then over here are people who are the worried well, or the well worried. Then we move into the wedge itself, and we'll have to divide that into 3 acts. Call this Act 1, and this Act 2, and this Act 3. Now, as we've been working with this, particularly with medical students, trying to decide how to describe this and try to develop it so that it could eventually get into medical magazines so they could see what we're thinking, I suggested that these medical students go home and come back with some rather technical words that would describe this so that it could get into a medical journal. And so they came back and they said that they had decided that the name of the first act should be, and this was a pretty technical name, would be Little Bit Sick, those rascals. Then Act 2, they said, should be called Sicker. And Act 3, the technical name would be Really Sick. Now, as you look at this and ask the question, how do people get sick and what happens? Well, something happens out here in the worried well area, and then eventually they move into the sickness part of it, and let's just say here's a person who is just a little bit sick, and let's make that you. You are not feeling up to par. You have to be your own doctor, and you have to be your own doctor 99% of the time. You make your own decisions as to how you're going to respond to problems. And you make a diagnosis. Your first diagnosis is, let's say, I think the reason I just don't feel up to par is that I've been burning the candle at both ends. And so you are a diagnostician, making a diagnosis just like a doctor. Then you have to decide what your treatment's going to be as a result of the diagnosis you've decided on. And like a doctor, you then try to hold yourself to the treatment plan, and let's say you decide that you're going to slow down, you're going to get more sleep, you're going to get more exercise, you're going to learn to say no more effectively. And if that was the proper diagnosis and the proper treatment follows, instead of getting sicker and moving into this wedge, you reverse the process and you get weller, or you are feeling better. Now, most of us do this over and over again, from time to time. But sometimes we don't go through with the treatment. We know we ought to, but we don't. So we move along here, and about halfway through Act 1, we find ourselves saying, I just can't do this by myself. Maybe I ought to talk to somebody. Or maybe somebody talks to us. And that's, I'm thinking particularly of the spouse, usually a wife who gets after her husband, and she says, George, if you don't slow down, you're going to get sick. And do you know how I can tell when you're getting close to getting sick? No, how can you tell, he says. It's because you get so irritable. And George responds, I am not irritable. But we all do that. But in effect then, the spouse becomes the doctor and gives us a diagnosis and treatment and gets after us, and usually that works. And so we revert back and we get well again. But sometimes we don't listen to our spouse or some friend, and we move a little farther along, and now other friends begin to notice that we aren't what we thought we were. We thought we were able to keep this from people to know that we weren't up to par. So here's a group of people talking to a girl, a woman, and they say, Martha, we're concerned about you. You haven't looked well. Have you had a physical exam lately? Ooh, this usually gets people to do something about it. So friends here are very important. Here is the family, in other words, or the spouse. The family got after us and we followed their advice maybe. But friends are also very, very important. And if we listen to them and they are accepted by us as our doctor, as it were, we then get well again. Now, all of us go in and out of Act 1 over and over again. And this is just a natural thing. We're in and out of Act 1, taking care of ourselves. Now, you notice that we don't have any professional people here, no doctors or nurses at the present time. And what I'm particularly getting at is that I see the importance here in the field of preventive medicine, and I'm going to come back to this later, for all kinds of organizations and churches and other groups that help one another to stay well, to be recognized as a part of the whole field of prevention, preventive medicine. Now, suppose you don't listen to yourself or your family or your friends. You then move into Act 2. And Act 2 is where you are feeling sufficiently uncomfortable that you decide to see your family doctor. So you go to your family doctor and you tell her your troubles, and she listens to you and she gives you a complete physical, and then she says, you know, I really think your problem is related to your lifestyle. And that's a word that most of us don't want to hear from a doctor. In fact, doctors say whenever they mention that word, the patient becomes defensive and begins to say things like, well, I had these same physical symptoms a couple years ago, and I went to a doctor and he gave me little blue pills, and I felt fine. In other words, give me blue pills. Don't make me change my lifestyle. Nobody wants to change their lifestyle. And this is one of the things that doctors tell me over and over, that they try so hard in the few minutes that they have a patient in an examining room to tell them you ought to stop smoking or you ought to get more exercise or whatever. And they say 6 months later when the patient comes back, there's no change, just the same. So they get discouraged, and I can see that, because we know that to change anybody's lifestyle is a long time process and usually requires that the person be in relationship to other people who are going through similar kinds of problems. But suppose that you do listen to this doctor, and this was a proper diagnosis, you then get well again. But suppose you go to a doctor who isn't interested in lifestyle and gives you the blue pills maybe, because it's easier to handle you that way, and it really doesn't do the trick this time, and you get sicker and sicker. And finally you're over here at the end of Act 2, and the doctor says, I think you'd better come into the, let's call it the community hospital for a checkup. So you go into the community hospital and you spend 2 or 3 days there, and they give you all the tests, and they do a great job of taking care of you and listening to you, and the nurses are very helpful with tender, loving care, and you get well again. Now, most Americans don't get sicker than this over large portions of their lives. They're taken care of by the family physician, the primary care doctor, and by the local community hospital, and that does the trick. But it doesn't always work. So suppose you continue to get sick. Now you move into Act 3 of this whole picture, and now your problem is bigger than it was before, and your family doctor says, I would like you to see a specialist in this field, a friend of mine who knows a great deal about this particular kind of problem. So you go to see the specialist, and the specialist is really concerned about the fact, and all specialists, I think, could be said to be concerned about the fact that they often don't see patients until the third act of illness. One of them wrote this up in a medical journal, and he said, being a specialist is like going to the theater, but not being able to get there until 10 o'clock at night when the third act had already begun, and you slip into your chair and you watch the players and you listen to what they're saying, and you have a dickens of a time trying to make any sense out of this play because you didn't see Act 2 and Act 1. And so the specialists are saying, if only we could see patients earlier. And the family doctors are saying, if only we could see patients in the first act. And I wish I could say that that is happening, but in our present healthcare system, it isn't working very well. Specialists tend not to see people until later. Family doctors tend not to work in the first act of illness. But say you go to this specialist and the things work out well, and you get well again. And I've had my occasions to go to specialists who made things work out well, and I'm grateful for specialists, believe me. But sometimes it doesn't work. So you go back, and finally about here, you're feeling worse and worse, and the specialist says, I would like you to go to my alma mater, the teaching and research hospital where I took my training in the medical school, because there's a super specialist there. This is the teaching and research hospital, where the super specialist is. And those people put their heads together in remarkable ways and do a remarkable job, and often we are healed through their efforts. And we are grateful for the tremendous progress that's been made in the whole field of medicine and surgery. So here we are. Well, one day as I was describing this to a group of doctors who were all teachers in medical schools, one of them said, this is a fairly accurate picture of American medicine as we see it, but this one man said, I was thinking of a wedge going in the opposite direction. And I said, come on up and show us. So he came up to the board and drew his wedge, and it looked something like this. Now he said this wedge going the other way is to describe all the people in America who are ill on any given day. He said the best educated guess would be that 60% of sick people are in Act 1. 60%, I said, and the other doctor said, yeah. These are the people who are buying billions of dollars worth of things over the counter that are not prescription drugs just to try to stay on top of their illnesses. Everybody seems to have something that they haven't been able to accomplish. And they're buying, trying this and that. And he said, they said, 60% is about right. 60% of people are in the first act of illness, and they're really not being seen by physicians. They're not being taken care of properly. We'll come back to Act 1 again, as I said earlier. Act 2, he said, has roughly 30% of sick people in it. These are medium sick people who are being taken care of by primary care physicians, and there's a fine relationship usually between the patients and the doctors, and they trust each other, and this is where really good medicine is practiced in most cases. At least he said this is where we ought to be giving much more attention to it. But he said what I'm really getting around to is Act 3. Act 3 has only 10% of sick people in it. But this is where all the excitement is. This is where all the hoopla is. This is where all the TV shows are. And this is where he said, well, this is kind of interesting, because we then got into this discussion, which was, I said, well, what percentage of doctors are in Act 1? And the answer was about 1% of doctors are in Act 1. How many doctors are in Act 2? And the answer was about 29%. They said 30%, but with the 1% gone, that leaves 30%. 29. Then we come over to Act 3, and the answer here was that 70% of the doctors, is that right? 70 and 30, yeah. 70% of the doctors are working in Act 3. These are specialists and super specialists. 70% of doctors are taking care of 10% of the sick people. In the audience was the dean of a medical school, and he said, I've got to show you where the medical school is on this chart. And he drew another line here. He said, the medical school is right here in this little section here. This is where we train young people to become physicians. Med school. But he said the patients we see in our teaching and research hospitals are really, they really make up only 1/10 of 1% of sick people on the average day of hospital care. In other words, the medical students are being taught essentially by super specialists and specialists, and they're seeing only the very, very sick people. And he said, this is what our real problem is today. And he said, and this was about 10 years ago, this is what we've got to change. And he said, what we're doing at our medical school is we're sending our medical students not into the wards of the teaching and research hospital, but out into the community hospitals where they will be able to work with family doctors, where they will be able to see people who are just sick enough that they can be handled by doctors and don't always have to have all of the special things that are available in a teaching and research hospital. Because this is the group of doctors that ought to be increasing in America. As long as we teach them here, and they're taught only by super specialists, they get the idea that that's real medicine, and this kind of medicine is just kind of second-class medicine. Well, the good news is that this has been happening now over the last 10 years, that more and more medical schools are sending their students during the first 4 years, not during residencies, but during their first 4 years, out to community hospitals and to neighborhood clinics, where they're working with doctors and patients and families and get to see how exciting that kind of medical care can be. Well, then we began talking together about what would be the ideal number of doctors in each of these three categories. And they immediately said, this 70% should be changed to about 30%. Because that's all you need, is 30% taking care of 10% of the sick people. There are too many surgeons now, too many this and too many that. And the next number they came up with was that this ought to be changed to about 65%. If 65% of doctors went into primary care, this would keep people from getting this sick and would be in the field, in a sense, of preventive medicine. Well, this kind of pleased me because this gave me then 4% more for the first act, which I'm so concerned about. And their reply was, forget it. Doctors did not become doctors in order to take care of little bit sick people. They came into medicine because they wanted to really help their fellow humans who were very sick. And some of them say that they know that one good grandmother is worth 2 pediatricians. And we know that a lot can be done without super training. But if this is to happen, we will find ourselves in, I think, a pretty ideal situation. The good news also is that our graduates now, over the last 10 years, have been gradually moving away from the 70% toward the 65%. But it isn't there at all now. I would say it's more like 40%, 30% perhaps. That the 40%, it's up from 29%. Now the question is, what do we do with this 4% if they're not going to go into Act 1? Well, the doctors said, you've only got 3 acts of illness there. Why don't you add a 4th act? And I said, well, the 4th act that I had thought of was the minister's role with funerals. And they said, no, there's a 4th act of medicine, of health care. The 4th act could deal with the chronically ill. And there's a new interest in chronic illnesses. The 4th act could deal with the whole area of gerontology. The 4th act could deal with the families going through losses related to the whole business of trying to think of the name of the new group that's developed hospice, the hospice programs, of course. So that you've got all kinds of things going here, and there is a new interest on the part of many young doctors in chronic illness and gerontology and family care and hospice care. And this will all be interrelated to Act 1. So they added 4% over here and 1% here. Now, as a clergyman, what am I suggesting that we ought to do about this situation if this is approximately what it's like? Well, first of all, there are a lot of people who have already been doing a lot of work in this field, in this area. And I'd like to mention the 4 groups that I think of offhand. The first are nurses. Nurses have long been interested in patient education and care. They've gone out of their way to do a teaching job for patients, particularly with cardiovascular problems, and doctors are using them all the time to teach patients. It takes a long time to teach patients how to do things like that. But nurses have long been interested in patient education, and I mean for the last 30, 40 years they've been interested in it. The second group are people in the social sciences. I'm thinking here of the people who are in psychology and in sociology, the social workers, and I'm also thinking of school teachers. And I'd like to just kind of write that in, school teachers, if I can get this to work. There we go. School teachers are in a position to pick up the earliest cries for help among their little kids who are going through problems of grief and loss, particularly where the child has lost a pet, for instance, or whose grandmother dies, or whose parents' marriage is dying. We've done some seminars with teachers in small towns where we've taken every teacher for a period of a day or 2 or 3 and worked with them in the field of grief and how to handle it because it's so prevalent in causing illnesses. And the teachers are very grateful because they find that they can deal with patients, with the little children, at a time when they are most moldable and most open to that kind of help. And we need to make sure that school teachers are given that kind of training. The third group are clergy. Some people don't know that for the last 40 years now, clergy have been invited to spend 3 months or a whole year in teaching hospitals, in hospitals of chronic illnesses, in the whole area of social institutions, social work groups, in mental hospitals, Clergy have spent time walking the wards with the doctors and the nurses. About 100,000 clergy have now taken 3 months of training in this kind of work. And they're just beginning to get their feet on the ground to know how to relate to the physicians and nurses of our time. The fourth group, which I think is the most important group of all, are lay people. Lay people are showing great ability to work with people who are going through difficulties. There's a Stephen ministry group, for instance, that takes lay people for a 50-hour course on developing listening skills and trying to understand the dynamics that cause people to become ill. And I see the potential here of developing these four groups in ways that we have not yet done so, except for an experiment that I'd like to close with. The experiment is to say, under the concept of friends, this is what congregations ought to be. And we're developing what we call a congregational health partnership plan, in which churches and hospitals can begin to work together. But congregations are made up of people. We hope they're made up of friends who are willing to be friends to people who are going through difficult times. Congregations have pastors who are trying their best to deal with the problems that occur in their congregations. But one of the things that we think now has to be developed is the whole matter of how do you organize this in a congregation? How do you make the congregation more aware that it really is in the field of preventive medicine? If a pollster were to come to your community and knock on the doors of the various homes and ask questions like, what are the health agencies in this community? What would the answer be? Well, we tried this, and we found that the average person immediately thinks of a local hospital or two, and then some maybe well-known medical clinic. And that's where it stops. In other words, these are our health agencies. Well, actually, health is more than just sickness. We're interested in health care as well as sickness care. But health care really takes place here. And we now feel that the health system of our day needs to have the additional help of people in congregations, because congregations represent the largest group of people in America. Maybe 2/3 of the people in America have some, at least tangential relationship to churches. So what we've done is to try out putting what we call parish nurses on the staffs of churches. These parish nurses are doing four things. First, they are health educators. They are spending time with people in the congregation in seminars, workshops, discussion groups, potluck supper groups, forums between services, and so on. They bring in other people to speak and also speak themselves. We have found, where we have tested this out in at least 100 churches now, that the people love this, and they feel that this is a part of understanding the total Christian life. Because after all, Christ himself, spoken of often as the great physician, was not interested just in the souls of people unattached to bodies. He was interested in the whole person, body, mind, and spirit. So this is a natural part of the work of the church. The second thing that the nurse does is to be a personal health counselor. And we find that the line forms to the right, because on Sunday mornings, many of these nurses now that are in churches are inviting people to come for blood pressure checking. And in some churches, particularly the Catholic churches, where you have huge numbers of people, 10,000 members, for instance, the nurse will have 3 or 4 other nurses in the congregation who are helping her. I say her because we don't have any male nurses as yet. We are looking forward to that someday. And about every 10th person says, could I talk to the parish nurse sometime about some personal problems? So there's no problem at all in getting people to come to the nurse counselor. The first group of people who came were elderly people. with their problems of medication and understanding the doctor's orders and so on. The second group were parents of teenagers with their many kinds of problems. The third group were men over 45 who said on leaving after they'd spent a half an hour to an hour just talking with the nurse, letting their hair down as it were, you know, I've told you things I've never told anybody else. I've never told my priest this, I've never told my doctors these things, never told my minister. And we think that the nurse is a unique person in our society because, in effect, the nurses that are on these staffs of churches have 1 foot in the sciences and 1 foot in the humanities, or 1 foot in religion and 1 foot in health. And this makes it possible for her to be the catalyst that brings these two professions of theology and medicine into some kind of conversation at the place where they ought to be concerned, namely the patient, because that's where they both meet anyway. So we found this to be very, very helpful, that the nurse is a counselor. But she can't do everything that she's asked to do, so she has to train other people to help her. And so she becomes a teacher of volunteers. And here we are back to lay people again. In one of our churches, we have approximately 100 people who took the Stevens Ministry course of 50 hours of training. And now this nurse has access to these 100 or so people who are willing to give an hour or 2 hours a week in some form of conversation with people who are going through difficult times. And finally, number 4, she is a liaison person with the medical community. She knows her way around the medical community. She can help people to find their way into this complex medical care system in ways that perhaps no one else can. And we find this to be a very helpful part of her ministry. These nurses now are related often to hospitals, a group of say 4 or 5 or 6 nurses who are in churches near each other, meet together in the local hospital where a doctor, family doctor, a nurse educator, and one of the chaplains sits with them as they continue their education to try to see what are the spiritual dimensions of illnesses, and will a person's relationship to God have anything to do with giving that person more stability in times of difficulty. We are convinced that the chief problem, or the chief ingredient, let's say, of either keeping a person well or making them sick has to do with their outlook on life. And this is what the church is concerned about, a person's outlook on life. I think you're going to hear a lot more about this over the next 25 years. And I hope that I'll be still around to enjoy it with you, because this is a new day of understanding the causes of illness in our day. And if 50% of illnesses are preventable, this is where it's going to happen. This is where it's going to happen. And as I see it, congregations are going to play a very important role. And we're going to say, when a person comes to our door and says, what are the health agencies in this community? They'll mention the hospitals and the doctor's offices, and hopefully they'll mention, and of course, the churches. And that's kind of the end of the story. Thank you very much.